that would be fantastic. And I'll just very briefly introduce you, giving you the short version of your bio. But Dr. Annalee Yassi is a professor at SBPH and is also a Canada Research Chair in Global Health and is also an occupational medicine specialist and has a long-standing research agenda in protecting the health and safety of healthcare workers. And has been, during the pandemic, the lead occupational physician for occupational health in Vancouver Coastal Health. So looking forward to your comments, and I'll turn it over to you, Annalee.
Yes, thank you very much, Chris. So my slide is visible right now. Is that right? Yeah, so you've really already introduced my various roles in this pandemic. It's really been service research, and teaching all in one. So the pandemic has really kept our group quite busy, really with the focus on protecting the healthcare workforce. So I'll speak to you about the service role that our group has been playing, as well as some of the research that we're doing, dovetailing with that, both locally as well as at the international level, because we're also a WHO collaborating center. So from the service perspective, when the pandemic was first declared, Vancouver Coastal Health realized that their medical staff wasn't serviced by their occupational health program because the occupational health program only focused employees, and the medical staff are contractors. So I was asked to quickly put together a service that would focus on meeting the needs for medical staff. So I was able to bring together public health preventive medicine residents, other doctors, graduate students from our from the school, and in close collaboration with infection prevention and control, as well as public health and employee safety, now called people safety, we set up a unit that would provide various functions necessary. Oops, I thought that would show better. Anyways, what POSH does, which stands for Physician Occupational Safety and Health, but really services all medical practitioners, including dentists and nurse practitioners and midwives, is really just provide expertise on occupational health and medical issues, answering questions about vaccines, protective measures, doing the contact tracing, also providing surveillance, talking to people about their concerns, helping people get their vaccines, doing sheets. I didn't update our stats since July, but you can see that we've had thousands and thousands of individual contacts with medical practitioners, everything about their own concerns to respiratory fit testing, to the whole gamut. We've also been doing information sheets on all these various issues, everything again from what to do if your kid is sick to issues around N95s versus surgical masks to serology testing, and trying to keep people up to date. This is an example of some of the surveillance that we were doing. The blue line is healthcare workers who are VCH healthcare workers, and the orange line is the background public general public rate of COVID. This is the rate per 100,000. And what you could see is that there were some peaks in the third wave where healthcare workers were having more COVID than the general population. But again, there were also some increased testing going on. But in the third wave, when vaccination rates were much higher in healthcare workers than in the general population, that healthcare workers were really quite well protected compared to the general population. And that's the case for positive cases as well as positivity, because more healthcare workers, of course, were being tested during outbreaks than the general population. So you could really see the impact that the vaccines were having on keeping healthcare workers below the rate of the background population. We also track vaccine effectiveness in our workforce to keep an eye on this issue of how long the protectiveness from one dose and then 2 doses would last. The green line being the rate of, the vaccine effectiveness, the rate of COVID in people with 1 dose versus 2 dose. And we found that at about the 42-day mark or so, a little bit larger, it was the 1 dose was just not doing the trick. So it helped, I think, bolster what was going on. We also learned in the course of this that, no surprise, that licensed practical nurses and care aides were at much higher risk of testing positive for COVID than medical staff. And unfortunately, this group also had a much higher rate of people not being vaccinated compared to medical staff. So since then, we've been focusing on providing support for long-term care as well. And as always, everything we do service-wise, we try to also dovetail with the research agenda. We got two CIHR, two big grants. First, about a $400,000 grant administered by IDRC in partnership with South African colleagues, and another smaller one from CIHR. Our first publication was in +1, where you can see that it's a partnership of occupational health, infection control, public health. You'll recognize Patty Daly and some infection control people, where we evaluated how the infection control, occupational public health, and all the measures were working, and sharing our surveillance data. Other research outputs that have, include the work that I'll talk about in a minute with the WHO from worker safety across the world, as well as some of our South African colleagues' work, and our longstanding partnerships with South Africa, and where that's at as well. Especially early in the pandemic, we were incredibly busy working with since we're a WHO collaborating center specializing in protection of the healthcare workforce from infectious diseases. We were part of an ad hoc working group on occupational health. We led the analysis of the WHO survey on workplace conditions, and I chaired the guidance development group. I was going to scroll down and show you the development group, but I don't want to take up extra time of what the guidance is actually showing. And so we're quite involved at the WHO level as well. The survey itself was administered in many countries, again, in the early stage of the pandemic. It was designed by the ad hoc group, not just by our group. The key results were, as would be expected. The African region had the most concerns about the inadequacy of the mitigation measures. The economic class, high-income countries had fewer unacceptable risks in mitigation, exactly what one would expect, but we drilled down. What was actually it's actually not on this slide, but quite stark to us is that the psychosocial concerns, the work organization and mental health concerns were as high as the concerns about getting the infection itself. So this also has gone in for publication, led by one of our SPPH graduate students and a medical student. So again, we really combine our teaching, research, and service in the work that we're doing. I'm not sure if I used up my full 7 minutes, but I wanted to leave lots of time for questions. So it's really, our work has been really busy at the local level, at the international level, and at the global level. There's lots of service learning opportunities and research opportunities, and we're still recruiting. So if anyone watching this wants to look for a position as an RA, a GRA or GAA, one particular aspect of our work that we promised to do in our CIHR grants, which could be expected and haven't done yet, is the gender analysis. So please do contact me if you're interested further in getting involved with our group. So I will stop at that. And,
great. Thank you very much, Annalee. And I'm going to hold questions and discussion to the end of all three presentations. But just before I move on, I'm just wondering if you could reflect for a minute on what was it like to transition from someone who may have been more focused on sort of more traditional research to actually having to go back into a clinical setting during this period of time.
Well, to be honest, I loved it because I had been really functioning as a social scientist essentially for the last 10 years. And so having an opportunity to put in practice what I learned in occupational medicine and in public health was really a great opportunity as someone who had become a full-time researcher. And it really showed how the research and the service dovetail and feed each other, and how being informed by the research really helps the service and vice versa. We're incredibly busy. working, 14, 16 hours a day at the height of the pandemic. But I mean, things have calmed down now. Hopefully, we'll stay calmer. But I think that being able to have a foot in both camps as a practitioner and as a researcher, you couldn't have a better scenario to put that to the test.
Great. Well, thank you for that, and we'll come back with some more questions once Sarah and Mike have had a chance to do their presentation. So I'm happy to turn and introduce Dr. Sarah Henderson, who I think many of you know well because she was the former OEH seminar coordinator before Angela took over. I guess, Sarah, you got a promotion or something. In any case, Dr. Henderson is the scientific director of Environmental Health Sciences at the BCCD Center for Disease Control, as well as an associate professor in the OEH division here at SVPH, and has been doing all sorts of work related to the pandemic as a consequence of her role at the BCCDC. So I will turn it over to you, Sarah. Thank you.
Thank you so much, Chris, and welcome back, everybody, to the school term. Nice to be invited to talk about a tiny fraction of what I've done as part of the COVID pandemic so far. And really, when I say what I've done, I mean what my team has done. A lot of what I'm going to show to you today, Angela was on my team when this was occurring, and Kathleen, who's another analyst on my team. This is really a lot of teamwork that went into this. And as Annalee says, those 14, 18-hour days actually sound quite familiar, and I'm mostly glad that they're over at this point. So yeah, I'm the scientific director of Environmental Health Services at the BCCDC, and I've got that in red because I've never even taken infectious disease epidemiology. It's not really something that's been of interest to me, but it really was all hands on deck at the center, especially in the early part of the pandemic. We're really kind of transitioning back to our core environmental health work at this point. And my slides don't want to go forward. There we go. Probably the primary reason that we got so involved in syndromic surveillance in environmental health services is because we do a lot of it anyhow, and because our team is very good with data. And I just want to start this presentation by saying data science I now consider to be fundamental to the modern practice of public health. And nothing has shown that quite as clearly as the COVID pandemic. It is underpinned by data. So this is just a screenshot of one of the many data tools available through the BCCDC website. The tools I'm going to show you today are strictly internal. They're for our users. We don't post them on the website. But knowing how to do this kind of thing is key, and certainly a good way to get into a great career in public health at this time. I actually believe it was Angela who developed most of what you're looking at right here. Syndromic surveillance is tracking potential indicators of a disease rather than the disease itself. So things that may be associated with that disease, but there isn't actually confirmation of the disease. We often talk about leading indicators and lagging indicators. Leading indicators are things that may tell you in advance that the disease is coming. Lagging indicators are things that tell you that the disease has already passed. They can both be useful and they both have their place, but the holy grail of syndromic surveillance is a very sensitive leading indicator. Syndromic surveillance is rife with potential pitfalls, and I want to talk a little bit about that and give you one example. And one type of syndromic surveillance you might be quite familiar with is digital disease detection, or using information from big data collected on the internet to try to understand what's going on with disease in human populations. And Google Flu is kind of the poster child for how syndromic surveillance and digital disease detection can go wrong. What we have here is a plot of the Google Flu algorithm over the course of a few years, and it performed very pretty well until we got to here, and then it went totally off the rails, and then Google retired it. So even though you have a well-performing surveillance system, things can change and change that performance. So in our own smaller example of how correlation may only be correlation sometimes, I want to show you what we were seeing in the very early part of the pandemic. So on the top panel here, we have the weekly number of COVID-19 cases by their symptom onset date. And in the middle panel here, we have the weekly number of physician visits for asthma by their symptom onset date. And if you are an epidemiologist of any kind, you cannot look at a pattern like this and ignore it. These two things are almost identical. So the question is asthma somehow an indicator that COVID-19 may be coming? It's perfectly biologically plausible. We know that respiratory infections do exacerbate asthma in people who have it. We also found that this was mostly true for people who might have sort of sporadic asthma. They weren't regular asthma services users. And when we looked at the dispensations of inhalers, we could see that these were increased kind of earlier than the visits for asthma and earlier than the case count started going up. So the big question is, do we have a leading indicator of COVID-19 infection in the population? And we spent a lot of time trying to figure out if that was true. 1 year later, we know it not to be true. So this is the third wave of COVID infections in the province. And this is what the asthma physician visits and salbutamol or inhaler dispensations looked like. You can see that the association that we could see early in the pandemic is just gone. And what we really had to conclude was that those associations were kind of driven by public awareness of the pandemic, people going out to get their medications filled because they were kind of worried about what was happening. And we ended up with this kind of spurious association. However, that doesn't mean that nothing useful came from this. And I'm just going to flip here to the internal tool that we developed for evaluating these syndromic indicators. So this is a Shiny app, and I'm not going to show you nearly what it can do, but what I do want to show you is the weekly number of physician visits for asthma. Sure, we'll go with that. And we're going to look at it by local health authority across the province. And here you can see, this is a full year's worth of data. This is last summer, this is this summer, this is a bit of time in between. And why these kinds of tools and these kinds of associations remain useful is here we can clearly see an interior health authority. This may not be associated with COVID-19 visits, but it sure as heck is associated with the amount of wildfire smoke that was happening throughout the interior region of the province during this period. And this will all be wildfire smoke last summer as well. So even though we developed some of these syndromic surveillance tools for COVID, they can still be really useful for other things. I'm just going to close that, take a second to launch the other tool that I'm going to want to show you in a second here, and then move back to here. The other thing we did was do a really deep dive into mortality. So mortality obviously is an indicating or a lagging indicator of COVID-19. But in the very early days of the pandemic, we were really concerned that there might be outbreaks happening in long-term care facilities that we weren't catching. There wasn't widespread testing at that point. We knew that long-term care facilities were highly susceptible. And so we developed these really rapid methods to take a look at those effects. And we developed what we call this standardized index of mortality intensity, which just looks at the mortality pattern at a single facility. And this is a well-known outbreak in North Vancouver, and then expresses the magnitude and the temporal density of the mortality that's occurring in this kind of index, and it's a Z score. So it follows a normal distribution, and we'd expect most of the values to fall between -2 and 2. So anything that's kind of above 2 is going to raise suspicions, and anything that is far above 2 like that sort of indicates that something suspicious might be going on. So we knew there was an outbreak in this facility, but we could look for similar patterns in other facilities and say, oh, maybe there's an outbreak there as well. And that's exactly what we did with this facility. You can see this is at the same time we have this big peak in mortality, but we don't have a known outbreak in this facility. This allows us to get in touch with the health authority, and then the health authority can get in touch with the facility and say, hey, what's going on here? What we found in this case is there was not an outbreak of COVID, but really sadly, some of the restrictions around that facility impacted the people who were in there. They were receiving a lot of care from the people who visited them, and when those people weren't allowed to visit, they didn't get that care, and there were very sad consequences as a result. So this is a real indication of the unintended consequences of our response to the COVID-19 pandemic. And I'll just flip back to R for you again for a second here. We are not running this app. I'm sorry, it's going to take just a second to load up, because I did want to show you this thing in action. It is super cool, and once again, very useful for examining other patterns in population health related to mortality. Come here, you. Oh, there's too many things on my screen. No, okay. Oh, I just want to maximize this, but I can't even move it. I will do it like this, and let's just take a look at a custom report, and we're going to take a look at a custom report for the province. We want to look at all deaths, and we want to show a 2-year period. Let that plug away in the background, and here we see something very interesting. So we can see sort of the impacts of the early pandemic here. We can see the impacts of the later waves of the pandemic here. These are still sort of within normal variability when we're talking deaths across the whole province here. But here we see the impact of the heat dome in late 2021. And we are in early summer 2021. We already know that hundreds of people died during that event. And it's quite starkly evident when you have a tool like this to look at it very rapidly. Back to there. So in conclusion, I just want to say the pandemic's been a huge learning opportunity. I think Annalee expressed sort of some enthusiasm for the way it shook up her professional life. And I think a lot of us at the center feel similarly. There was a lot to learn, very quickly. And even though it's been very traumatic on the global scale, I've enjoyed working on it. Data competency and creativity with data are invaluable. A lot of what we did is still going to remain useful, even though the pandemic hopefully will one day end, hopefully. And I just want to reiterate that climate change is another public health emergency, and one that is a little bit nearer and dearer to my heart. So thank you.
Great. Thank you so much, Sarah. And it's fascinating to see some of the I guess, behind the screen tools that you're working with. And certainly it seems that this has been an opportunity for data innovation here, in terms, perhaps driven by necessity. I'm going to hold off again on questions and turn it over to Mike, and I will briefly introduce Dr. Brauer, who is also a professor in the Occupational Environmental Health Division here, as well as affiliated with the Institute for Health Science, Clinical Sciences. Hopefully I got that right, down in the University of Washington. Mike, I think, as most people know here, has had a significant career in the area of environmental health, particularly thinking about issues related to air quality. And I will turn it over to you, Mike.
Thanks, Chris. I'm going to, I think this is actually great, because I'm going to give this from a kind of a very different sort of perspective and messaging from the previous two speakers. So kind of just a general theme about kind of how the science and research community interacted with the pandemic, and I think in some cases rose to the challenge and other cases did not. Just give you some examples, just how I've interacted with it. So if you go back to I guess a year and a half ago now, kind of the early days in the pandemic, we actually didn't know much about transmission, and we thought, or at least the prevailing wisdom at the time was that hand washing may be very important as a protective action. And so actually I wrote a paper over a weekend. We had access to a data set on global access to hand washing with soap and water as a result of aggregating a large number of surveys, and thought that we could make this data useful, and basically saying, even though at that time the pandemic was really isolated to a small number of countries, fortunately we knew that it was going to spread globally, and trying to highlight, well, here's some countries that are going to be very vulnerable, actually, because many people in those countries actually can't wash their hands regularly, and if we can plan for this in advance. Now, it turned out that, as we all know now, that hand washing probably has nothing to do, or very little to do, with COVID transmission, because of the airborne route. So this data itself wasn't useful, but having said that, we actually know, and we wrote the paper with this in mind as well, because we didn't think at the time that the pandemic was necessarily going to continue for so long and be so devastating. Even on kind of a normal year, our estimates are about 700,000 people die every year globally due to lack of access to hand washing. This is primarily due to diarrheal disease, but also some pneumonia as well that's linked to access to hand washing. So that was kind of the very first thing we did. And I guess, again, an example of, we took this data, we got it out there, not just did sort of a technical presentation, but also wrote a more publicly accessible piece for a policy audience in a venue called Think Global Health, and then did a lot of media attention, just again to make awareness about the issue for COVID, but also more generally, let's use this as an opportunity to actually improve hand washing access globally, because it is a risk factor for other diseases. The other thing early on was sort of getting into the issue of air pollution and COVID-19. Early on, as you'll remember, we had quite severe lockdowns in many parts of the world. Italy was sort of the first one, as well as China. And there was actually a lot of hype and a lot of poor science, basically, capitalizing on this sort of natural experiment that I think everybody knew wasn't going to last forever, about, oh, there's this economic downturn, these lockdowns, what is the impact on air quality? How many lives are quote unquote saved by that? So I got together with a number of colleagues, and we did write a piece sort of about, we need to be cautious about this, but also, again, taking the opportunity to say, well, here's an example of, from a scientific perspective, you can actually it is a natural experiment that you could capitalize on, and what can you learn from it? And again, this is just some examples. So this is satellite imagery for Vancouver in March 2019. For nitrogen dioxide, this is March 2020. So again, you can see, as would be expected, because nobody was driving, that first month of restrictions, a decrease. But of course, this is very short-lived, and actually the kind of more sophisticated analyses that have been done have understood that there's varying meteorology, that this was not going to last forever. And then in some parts of the world, for example, Northern Italy, China, that had, again, some quite dramatic but transient increases. When industrial productivity and activity rebounded, there was actually an increase level of emissions and higher levels of air pollution. So there was no sort of, quote unquote, saving lives by these actions. Having said that, there was a very important early early sort of interaction that was well known to us that did suggest that we needed to be careful about air pollution and COVID. And that's because we've known actually for a long time that there is a link between air pollution and respiratory infections in general. There's a lot of mechanistic work as well as some epidemiologic work. So the mechanistic work as shown here impacts on both on receptors, impacts on immune responses, so changing ciliated cells and changing our ability to clear infections, which then basically lead to increased severity of a respiratory infection in the presence of air pollution exposure. So this is just work of, this is a meta regression showing a concentration on the x-axis, and this is a relative risk, so concentration response relationship, looking at studies conducted various places around the world, both children and adults, and showing this sort of concentration response relationship. So the higher concentrations of air pollution, in this case, particulate matter, the greater the risk of incident lower respiratory infection. So again, mostly, so this is pneumonia, not specific to COVID, but this is prior information that we had that would suggest that other respiratory infections, such as COVID, would likely also be enhanced by the presence of air pollution. And so with that information in hand, and actually this was going back to spring 2020, Sarah contacted me actually about agricultural burning that happens seasonally at the time in BC. So that's typically a time when there's a lot of slash burning to get rid of agricultural and forest debris, which does create smoke that impacts communities, again, at the same time that we were starting to be faced with the pandemic. So we got together also with Chris Carlston in respiratory medicine and wrote an editorial piece for the Globe and Mail that got quite well publicized, basically making people aware of this link, and really with two key messages. One is that this is not the time to be burning, and secondly, we should be thinking about this as we move actually into the summer, thinking about wildfire smoke, for example, that there is this interaction that we know about, and we want to do everything we can to reduce the strain on the healthcare system. We should be thinking also about reducing exposure to air pollution. And then the rest of my interactions sort of with COVID during the pandemic have really focused on all the issues related to ambient aerosol as a transmission vector initially, airborne transmission in general, and then the issue of masks. And here's really where, for the students in the audience, when you get to learn about the basics of aerosol physics in the lab class, and something that I've been working on for more than 30 years, you can really take your knowledge and put it to use in all kinds of ways. We actually knew a lot about aerosol transmission, and it did take a long time for this to be recognized, and probably cost many lives because of inappropriate actions and control measures. But there were many opportunities once this became accepted to really intervene and get the message out and change both actions of individuals as well as public policy. So this is, again, an example of some work I did early on, looking at, again, taking information from published, mostly trials as well as some observational studies on the protectiveness for respiratory infections due to non-medical masks in the general population. Most of the early discussion and early debate was on medical masks within the healthcare population. And you heard Dr. Yassi sort of present some information on the healthcare population. And certainly that was well warranted for that to be the initial concern. But then as we became aware of airborne transmission in the general population, what about non-medical masks, and what about what was the evidence? And again, and this is basically showing that you got somewhere from our sort of synthesis of the literature, somewhere of a 40% protection in general and some studies showing much greater protection for COVID specifically, and that actually has become stronger with more evidence for COVID specifically. We use that, and this is together with the group that I work with in Seattle, use that in their widely used and widely publicized COVID forecast. So this is just taking a shot back. This is actually back about a year ago, almost exactly a year ago. I think it was the first seminar that we presented last year, showing that if universal mask use was adopted globally, at the time, you would go from a projected global death toll due to COVID of 2.8 million, which unfortunately we far exceeded already, to 2 million. So quite a large reduction in deaths. And you also see how this varies by country to country, depending on the level of mask use at the time. I'll just, if this works, I think I'm gonna have to stop sharing and just make people aware that this same tool, this forecasting tool, which is available for all countries in the world and Canada by province, we still have a mask scenario. And you can see that if we go throughout the course of this winter, the projections are still that by the end of the winter, even in BC, we may be able to avoid with universal mask use some 700 deaths or so. And you can look also at the level of mask use. This is taken from a number of surveys. So this is actually reported survey data. You can see the drop after the mandate was lifted. We haven't updated it with the surveys since the mandate was reinstated, but things will pop back up. And hopefully, actually, if we continue that mask use, we will be able to avoid some of the deaths that are projected. And let me just go back. So just to wrap up. And then, I've gotten heavily involved with just media in terms of trying to basically translate the science into useful information for the general public and hopefully also inform policy. So everything from ventilation, what we know about outdoor transmission, what we know about barriers, plexiglass, et cetera. And much of this really just goes to fundamental understanding of how aerosols move in the environment. I would say also, again, for those of you involved in occupational hygiene, also trying to get the message out, and this is still an uphill battle, that we actually should be thinking quite carefully about all the surface cleaning. I would like to say that there's no harm in surface cleaning, but unfortunately, someone has to do that surface cleaning. And for especially custodial workers, cleaners that are doing a lot of the cleaning day in, day out, repeated exposure to some of these cleaning agents, we know that those are respiratory hazards, especially some of the quaternary ammonium compounds that are being used. So it's not as though there's no harm to the cleaning. From the general public's perspective, there probably is no harm. It's not a bad thing to have clean surfaces, although it's not effective for COVID, and there is potential harm to some those in the occupational workforce. So trying to also get that message out, which I think is still an uphill battle, and it's still something that unfortunately is prominent in some of the UBC policies, for example, that are still active. So this is not something that's over. So I'll stop there, Chris, and hopefully there's time for some discussion.